All right, good afternoon, everybody, and welcome to the first all Behavioral Health Commission meeting in some time. I'm very excited to have everybody here. I wish we could be in person. That was the original plan. However, I think that we were respectful of the facts of the ground as well as some feedback from commission members and are taking advantage of our opportunity under the current public health emergency to hold this meeting virtually. It is live streaming on YouTube, and so we welcome not only the commission members, but those folks watching. My name is Jay Chaudhary. I'm the director of the Indiana Division of Mental Health and Addiction, as well as the chair of the Behavioral Health Commission. And we have a pretty full agenda today. We're going to go ahead and skip the roll call, just because I find that to be very painful personally. So I'm taking my own prerogative there. I did want to highlight a couple of new members. You don't have to say anything. I just wanted to say that Leslie Miller is now our representative from the Department of Child Services. So welcome, Leslie. Thanks for joining us. I don't see her on yet, but Jess Yoder is our new representative from the Department of Education. So if and when she joins, welcome, Jess. And I also wanted to share some very good news, and that is our creator, if you will, Senator Mike Kreider, who was the drafter and the creator of the legislation that authorized the Behavioral Health Commission, has now joined us as a member. He could not make it today; he's out of town. But I just wanted to pass along thanks to Senator Kreider, as well as his regards and regrets for not making it. We'll make sure we schedule around his schedule for the next meeting, because he will take on a lot more importance, along with the rest of our legislative members, as we get closer to our recommendations. So we have a jam-packed agenda. We are going to hear report outs from all 6 of our subgroups, and we'll kind of get to what that entails. But before we do, I just wanted to take care of just our only real piece of business, which is review and approval of the February meeting minutes. So this time I'll open it up for a discussion of those minutes. Does anybody have anything to add or edit from those minutes? Okay, can I have a motion to approve?
I'll move to approve.
Second.
I'll second.
All right, and all in favor, if you could unmute yourselves and say aye.
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 And if opposed? All right, the motion carries. Okay, thank you. All right, moving on to the bulk of our work for today. So if for the folks watching at home and for the commission members that may not remember or are new to this, we, as you may recall, back in February, we came to you with a proposal to kind of divide up this massive undertaking of understanding and reporting out on the and making recommendations for this massive system, right? And so we had a proposal to divide up into work groups. We got some great feedback from commission members and ended up with 6 different work groups, and that was those work groups are overall mental well-being, continuity of care, criminal justice interface, children and families, behavioral health workforce, and suicide prevention and crisis. This may or may not cover all of it. I think that's something, an open discussion that we'll have after the subgroup report outs if there's time. But we, so over the spring and summer, we were hard at work. We had 15 meetings, different subgroup meetings of our Behavioral Health Commission subgroups. And here at this point, I have to just take a moment to thank the DMHA staff working on these subgroups, because it has been just a massive undertaking. And so Elaine Trepanier, Amy Brinkley, Kelsey Linville, Alexis Pless, Bethany Eklor, and Jocelyn Pachaki, thank you so much for all your hard work on this. We would not have been able to do this without you. Again, thank you. We had 15 subgroup meetings in about 4 months. Each of which had to be live streamed on YouTube, as well as the logistics of the Zoom figured out, not to mention just the juggling of all the other responsibilities. So thank you so much. We really appreciate it. So I will share just a little personal story about how I react to these meetings, just I think to give you a sense of the magnitude of the task ahead of us. So look, I have a very difficult job, and I also don't generally get flustered. Those are two things you should know about me, right? Okay. I am a hot mess before any behavioral health commission meeting. I'm like nervous. I'm like sweaty, just like real, just not just out of sorts. Before every single subgroup meeting, and Rachel and I made it a point to attend every single one. And I think it's just because of the magnitude of the task and the importance of the task. I just, I have like some serious doubts about, my ability to help shepherd us to where we need to go. But every single time, every single meeting, I end up thinking that was a very silly way to feel beforehand. I'm moved by the passion and the ideas and the brilliance of our commission members, and I always end up feeling like we're in a pretty good place after the meetings. And I can say today, before this meeting, I did not have that nervous, sweaty feeling, because I know that we're in a pretty good place right now. We're not finished. We're nowhere near close to finished. Our report is due in October of 2022. And I think that we're well on track to meet that deadline. And the subgroup work that we're going to get into will, I think, illustrate that for you all. We sort of made the decision between myself, Rachel, and the subgroup chairs to not have voting items today, because I think that we want to do instead present the direction of the subgroups, open it up for feedback and discussion, and then have the subgroups take that feedback and those reflections and any other thing that's brought up, and then come up with, I think, what would be like the final draft of those subgroups for a voting at either the next commission meeting, or, depending how it goes, the one after that. I think we are well on track, again, like I said, to have this report done really well by our deadline. So before we jump into the subgroup presentations, I just wanted to pause here to see if there's any comments or questions about the kind of work and the mechanics of how things are going. All right, so let's go ahead and jump right in. And I am Bethany, if you can share the slides. We've combined everything into one slide deck. Again, thanks all to the DMHA staff. And I am the de facto chair of the overall mental well-being subgroup. And so I'll go ahead and kick it off, and then we're going to go to continuity of care with Katie Adams and Carrie Cadwell, and then the criminal justice interface with Dr. Negadank and Katrina, children and families with Brooke and Chase, behavioral health workforce with Katie and Carrie, and then we'll end up with suicide prevention and crisis, which is me. So that is our agenda, and we'll go ahead and get started. Okay, so the overall mental health and well-being subgroup, I think, was a recognition that when we talk about behavioral health or mental health or whatever the word is you're using, we're actually talking about several different things, right? We're talking about the system as it exists to treat people with SMI, but we're also talking about people that are, and this illustrated perfectly by the mental health pyramid that Barb first shared with me, that I think is a really important way to look at this. And I think that we need to also pay some attention to the people that are, again, I don't like the term, but I think it's an illustrative term, which is like the worried well, right? People that may have underlying or pre-existing conditions, may not, maybe triggered by societal events like we're going through right now. There may be stigma about them, in terms of them identifying that they have an issue. And so I think that we wanted to make sure we left space for a discussion of something other than just that kind of SMI phase. This was the charge of the subgroup. And so Dr. Bowman, Mimi Gardner, Ray, Lay, Barbara Scott, and myself were on this particular subgroup. And we had some really, really good discussions, and we came up with the following recommendations. If you can advance the slide, Bethany. So the first one was a long discussion, and so just as an aside, I think that one of the things that the subgroups had challenges with was how do we make our recommendations concrete and actionable, and not just like a, hey, you should make the system better type of thing, which is like not, obviously something we all agree with, but not really helpful to anybody. And so, we had a long discussion about social determinants of health, which are the factors that drive a person's health and mental health that aren't necessarily related to like what's strictly defined as healthcare, right? And so, an area that several states have taken a look at, and that we think that the commission should recommend that Indiana take a look at, is exploring and adopting the notion of paying for housing support, in particular, but also other social determinants of health through the Medicaid program. When this goes into the final report, if in fact it does, we can pull from those other states examples for sort of a more concrete illustration of what we're talking about. But I think that across the board, when you survey the people in recovery or people they're professionally in the treatment world, housing comes up constantly as a major factor and major barrier for overall mental well-being, as well as the ability of folks with SMI and SUD issues to maintain a healthy engagement with treatment. And so, recommendation number one, and again, this will be fleshed out, but we wanted to show the direction of this was that the state should take a more active approach, like several other states have, and leverage the Medicaid program to pay for social determinants of health issues. So, any questions or discussion on number one? All right, cool. Obviously, I think there will be many opportunities yet to weigh in on both the general direction as well as whatever specifics we end up coming up with. So number two was this is all credit to Barb Scott here. This was her passion and her idea to really make an effort, kind of inspired by the Know the Facts campaign, but also not limited to that. I think that the truth is this has to be not just a government effort, right? This has to be a private sector and philanthropy and business groups and schools and local governments and all the relevant folks to advocate and work for increased mental health literacy. The nice thing there is that there are existing evidence-based curriculums and programs that we can take a look at. And again, we're going to flesh that out when and if this ends up in the final report. A really important thing I wanted to make sure to highlight was the notion of a culturally competent and responsive mental health literacy curriculum. And major shout out to Dr. Bowman on this particular piece, because I think she spoke very eloquently about the importance of this, and this has to be built in. We have to tailor what we're doing to the audience, and I think that just both from a kind of moral and equity lens, but also just from an effectiveness lens. And so we want to make sure that is built in there. And the other thing that Rayleigh, I think in particular, was very cognizant of is that we need to make sure we include messaging that is driven by and focused on folks with lived experience or who are currently in recovery, similar to how we've done with Know the Facts. And so again, this is recommendation number two. Any questions or comments? Thoughts? Subgroup members, do you have anything to weigh in on? Ray, you're on my screen, so I'm gonna call you out. Do you have anything to add to that?
I know you should be happy that your screen's still working first.
Absolutely.
Okay. But just like the parody goes, mental health and substance abuse, that's the reason why I had to bring that up. I mean, me, myself, I fit both categories, but also I fit the category of not only outcomes, but possibilities. And specifically also with both of these major recommendations. With the housing supports, yesterday, I was part of the 30-year symposium, a 30-year anniversary symposium for the Corporation for Supportive Housing, a national nonprofit. I actually was a moderator of one of the breakouts, and I received a community champion recognition. And unfortunately, but truthfully, I am a person with severe mental health issues and also substance abuse issues. I believe that these are good. They will help bring out more persons to seek out recovery. Okay, that's just me. And thank you very much, Jay.
Yeah, absolutely. Thank you, Ray. Really appreciate your contributions, both to this group and the other groups that you're on. It was really great to have you there. So this is sort of it for this subgroup. I think that they will not all be this short, but this is one I think that we were able to really hone in on and come up with a couple things I think to really frame, and we're leading with this, I think, for a reason, I think, because this sort of frames the rest of the discussion. So yeah, any last comments on the mental health well-being recommendations? If we don't hear any, we're going to assume we're on the right direction, and then hopefully come back to you all with slightly more fleshed out recommendations for sort of inclusion in that final. So, and just to add, there'll be two, I think, as I see it, again, this is subject to change, but two more opportunities for full commission members to weigh in on everything. I think that next one will be at the next meeting. And then obviously we will have a draft report that will circulate to you all for comments before we get to the finalized one. So definitely opportunities, not a speak now or hold your peace situation, but look forward to any, if something strikes you later and you want to chime in on it, go ahead. Reach out to us. All right. Well, thank you for listening to that, and thanks to the subgroup members for your great work there. Okay, moving on. And these next two are I think the most dense of the two. Just full disclosure, but I think it's really important, really great work being done here. So. I don't know if Dr. Cadwell or Katie Adams is taking the lead on.
It's me. I'm going to do the next one, and Carrie is going to do workforce.
Okay, fantastic. We'll take it away, Katie. Thank you.
Awesome. Thanks, Jay. So the continuity of care subgroup met twice. The subgroup members included that list there below: Steve McCaffrey, Barbara Scott, Dr. Carrie Cadwell was co-chairing with me, Dr. Tim Kelly, Mimi Gardner, and Mayor Scott Fadness. So thanks to the subgroup members for participating. Our first meeting was just a really rich discussion about the gaps in the continuity of care for folks in their journey towards wellness. We talked about various barriers for not only the professionals providing the treatment, but also for the consumer. As well as just big gaps and opportunities that we saw for those going through treatment. So we ended up having 12 buckets or 12 topics that we came up with from our initial discussion. And then we did like a priority polling through SurveyMonkey with the subgroup members to try to find what are the top 2, 3, 4, 5 things that we think are priority here out of this list of 12. So there were a clear 4 items. So we did have a top 4 from that polling. And so from those 4 topics, we were able to develop recommendations. So if you go to the next slide, the first category was talking about treatment extenders. So, some of the workforce challenges kind of bled into this committee as well, of course. But thinking about workforce challenges and the needs to provide treatment outside of just the traditional model of seeing a therapist once every other week or whatnot. We discussed treatment extenders and the need to have, the first recommendation is having a training program, certification, and or licensure for those non-licensed staff that are so essential to the work that we do. And also tying that certification or licensure to reimbursement rates that are sustainable for the services that they provide. So that is key, we felt, in moving forward and getting out of the more traditional model of treatment and using treatment extenders. The second part of that was addressing the issue with telehealth services and the non-licensed individuals. So maximizing the use of telehealth services by adding these treatment extenders that we're discussing in this first item to those who can provide mental health and addictions care via telehealth. So that's recommendation one, is kind of legitimizing that profession with a certification that's reimbursable and part of our treatment team. Any questions on that first item, or maybe some of the committee members have something to add?
Just one clarification, Katie, and that's I think that there might be, I think there was a question raised about, do peers fit into this?
Yes.
Just to clarify. Thanks.
So it's peers, it's other behavioral health professionals, all of those folks.
Yeah, and of course we'll develop that much further before and as it goes into the.
Sure. Okay, well, moving on to the next one. The next one was an obvious one, was access issues. So we came up with 3 different recommendations that have to do with access. The first has to do with just ability to share data and information, clinical information for all levels of care. So not just mental health professional to mental health professional, but the ability to share medication information, the ability to have a data system that can be shared with emergency professionals, hospitals, CMHCs, county jails, Department of Corrections, so that we can have seamless care for individuals, so there isn't this disruption in care because of lack of information. So that was the first item, is to look at some sort of shared data system that people can access to get the information they need. The second was exploring best practices with centralized case management systems and looking at possibly what the managed care entities are using with some of their care management strategies. So how can we partner with MCEs, or how can we look at that model to help with some of the navigation issues with people going from one level of care to the next? The third one is evaluate current intake processes and develop workflow to reduce barriers to access. So we all know there's administrative burden to access. So looking at the administrative burdens, looking at how we can address immediate needs in a trauma-informed kind of way, when somebody needs it, where they need it, without having all of the hoops of scheduling intakes and all of the administrative burden. So looking at that intake process and developing recommendations for change. Any questions about access issues or anything from the committee that you want to bring up? Okay, let's go to the next slide, to number 3. Can we get the next slide? I don't think I have it memorized. Okay, yeah, there we go. So parity was the next one. New York has a blueprint for parity. There is a link that I could share that Jay shared with me. But they have a blueprint of how they are assuring parity for mental health and substance abuse treatment. And so looking at their blueprint and developing recommendations for Indiana on how to address issues related to having a medical necessity definition that's followed by everyone, centralized credentialing, and standardized prior approval processes. So we all know these processes with medical necessity, prior approval, getting people credentialed, delays access to providers. So looking at those issues, and New York has a blueprint that we could get ideas from. The second is to review the parity recommendations brought forth by the Commission on Improving the Status of Children. So they have a parity committee that recently has developed some recommendations that they're going to be bringing forward to empower the enforcement of parity in Indiana. So looking at those recommendations, review them and see what comes of that. Steve, I know you have more information. You're on that board. Are those recommendations public at this point?
So it's been a 2-year process actually, and IDOI is putting together a review that will be brought to the Parity Committee at a meeting coming up in October. And then the Parity Committee will look at the findings from IDOI and make recommendations at that point that we'll then bring to the commission.
Super. So already some great work being done there that we can get some great information from. Any questions about the parity topic or comments any of the subgroup members want to make?
Just a clarification, just for folks that might be watching that or that aren't aware. So parity refers to insurance parity. So the notion is that that there's a federal law that mandates that insurance companies or insurance plans can't treat mental health conditions differently than kind of equivalent medical or physical health conditions. But the enforcement and the teeth of that are kind of all over the place. So that's just again to clarify for folks watching this, that's what we're talking about. And this is a really powerful tool that we're excited to maybe help take to the next level.
And Jay, I just add in there, what you said is exactly right. But our parity committee has actually talked about trying to broaden the way we look at parity to include issues of equity as well. And frankly, finding that a difficult path, but it's a path we want to go down. So just to make everybody aware.
That's awesome. Thanks for sharing, Steve.
This is Ray Lay, and I would just like to go back on what you're speaking on as far as what I believe would be like electronic health records.
So that was the item with access. We were talking about the ability to share data. Is that what you're referring to?
Yes, most definitely, definitely. And I had seen about Ohio and Kentucky, and they are actually doing it already, right?
Well, I know that Ohio has an information exchange and Indiana also has an information exchange, but whether or not it has the participation it needs to be effective, or whether or not it's working well is what would need to be talked about.
Okay. Well, I just would like to add, I am a veteran and enrolled in VA healthcare. I can go see a doctor in Florida, New York, California, Nevada, or here in Indiana, and have seamless care across the whole continuum. So I'm all for that.
Yep. Well, and if you Google IHI, Indiana Health Information Exchange, on their website, it has the participant list. So you'll be able to see who is currently providing that data. And so it's still limited. So again, it's just something to explore, but I mean, the VA health network, I think, is the gold standard, right? You should be able to go anywhere and get seamless care and have the information that, or the physicians or the providers have the information that they need. So I agree with you, Ray.
Thank you. And I say that was great recommendations.
Yeah. All right, so back to parity. Was there any other comments about parity? Thanks, Jay, for clarifying that. Okay, so the last one had to do with the crisis continuum. So there's a lot of gaps currently. So when somebody's in crisis, it's not something that is over in an hour. It's something that tends to linger, maybe even up to 90 days. And so talking about the continuum of care for somebody that's in crisis. So the first recommendation is for the state to fully endorse and certify certified community behavioral health centers, which are CCBHCs in Indiana, with a supported Medicaid rate or fee structure adjustment that supports cost-based reimbursement. So there are, I think, 16 CCBHCs in Indiana. I might have that wrong, but somewhere around there. And this is a way of paying for services that aren't normally reimbursed, like crisis services, and helps us, provide those services or provide those gaps that are currently existing in our communities. And then the second was to evaluate the Kentucky and Ohio models of maintaining Medicaid coverage for those that are incarcerated and develop best practice for Indiana in assuring coverage is maintained during incarceration. So that's another barrier for folks in crisis, that folks that are in and out of jails or Department of Corrections, is assuring that they're getting access to treatment and have a Medicaid as the payer source. So any other comments on the full crisis continuum gaps from the committee or the subgroup?
One question. Hi, this is Lindsay Baywa. I'm representing Allison Taylor from OPP here today. In the questions of parity, was telehealth brought up at all as a concern or question for parity, or was this mostly just the medical versus behavioral health or equity piece?
So you were a little garbled, but I think you were asking about telehealth. So we talked about telehealth as far as expanding to who can provide telehealth. Was there something else?
Correct. Sorry if I might not have the best network connection here in the office, but my question was concerning with telehealth, like I guess from the Medicaid side, it'd be more linked to reimbursement, but also just service coverage. Would we expect also to be parity that we want it to be that in-person versus telehealth services can, both be on similar playing fields?
Mm-hmm.
Okay.
I think there's a deeper dive in there for sure. Other comments from the committee or from the subgroup? I think we may have covered it, Jay.
Yeah, that was great. Thank you so much, Katie. So
Sure.
we'll kind of continue to work with you all to flesh out and add some detail to those and to turn I don't see a whole lot changing, but there may be some slight tweaks or additions as we do a little deeper dive into some of these things forward. So thank you so much. And thanks to the members of that subgroup for a lot of really hard and intense work. I think I can't remember if this one or a different one, but there was, I think it was this one where my head was just spinning. I think after that first meeting, I was just like, what is happening here? But you guys did a great job of kind of winnowing it down and getting it to something that was, much more palatable for everybody. So thank you for that. All right, moving on to the criminal justice interface. I think as we know, unfortunately, that the criminal justice system is the largest or one of the largest intersections with mental health and SUD, and for better or for worse, that's just kind of the way things go. And so we had a fantastic subgroup here, and I'll turn it over to Katrina and Dr. Negendank for this particular piece.
Yeah, thanks, Jay. I'm going to be the main presenter, and Katrina's going to join in to assist if I forget or leave something out. As Jay pointed out, the subgroup charge, I'm not going to read it, but basically we're looking at best practices around these interfaces, right, between mental illness and addiction and the criminal justice system. And we, I think all the committee members are incredible. I think our subgroup was incredible. There's such a depth and breadth of knowledge there and a passion behind this. So it's really been great to work with this subgroup. Myself and Katrina are the co-chairs for this group. I know we're both honored to be able to co-chair and assist with this way. And, personally, I'm an adult and forensic psychiatrist and also certified in addiction medicine. So this has been my life. And so I was just really excited to be able to be a part of this. We've had a great subgroup. Like I said, there's myself, Katrina Norris, Mr. Ray Lay, Chief Chase Lyday, Lieutenant Anthony Mays. And there's a few more on the next slide, if you can see that one. Thank you. Mr. Steve McCaffrey, Sheriff Mike Nielsen, and Dr. James Nawson. So thank you to all the subgroup members. And I think as I present this, what I'm going to do is just pause after each intercept. And if anyone has anything to add or questions, just go ahead and jump in. If I don't hear anything, I'll just move on. Okay, so can we have the first slide, please? Okay, so when we started thinking about our recommendations, we really wanted a way to organize the recommendations. And one way that has been useful for many years now is something called the Sequential Intercept model. And that is what you see here, the first graphic. And I know not everyone is familiar with this, so I'm just going to spend a minute talking about it. The Sequential Intercept model really provides a conceptual framework when considering the interface between the criminal justice system and those who are in the mental health and addiction systems. And it envisions this series of points, which you'll see here as intercepts, at which an intervention can be made to either prevent individuals from entering the criminal justice system or prevent them from penetrating deeper into the criminal justice system. And ideally, we want to get the majority of people at the intercepts early on, so 0 and 1, prior to any interaction with the legal system at all. This sequential intercept model has been out for a long time. I think the initial article came out in 2006. And since then, it's really spread nationwide and has become standard of care. And we chose it for two reasons. One, as I mentioned, to really help us organize our recommendations. And the other is that the state of Indiana has been looking at this model and starting to adopt it. And so many in the state legislature also understand this, and we wanted to continue on in that way. So I'm going to go ahead and start talking about the intercepts. Intercept 0, we are not making recommendations on that, only because the other subgroups are looking at that intercept. So that intercept, we consider it the ultimate intercept. So it is a accessible, comprehensive, effective, evidence-based mental health and addictions treatment statewide, right? So that is really best practices. But we know that the other groups are looking at that. So we are moving on and really starting our recommendations at Intercept 1. So Intercept 1 is law enforcement and emergency services. And our main recommendations along in this intercept is to expand our crisis intervention training. So many are aware, but for those who are not, crisis intervention training really started back in 1988 in Memphis, Tennessee, spread nationwide. It's now a training that is in over, I think, 2,700 communities at this point. So it's a 40-hour training for law enforcement with the aim of improving outcomes when officers are in the community and interacting with individuals who are struggling with mental illness or addiction. It really promotes engagement in treatment, diverts people out of the criminal justice system, and develops improved communication and trust between law enforcement and the community. So we do have CIT programs here in Indiana, but it's not consistent. We need more training. One of the most difficult things is funding. And in my work in jails and prisons is that this came up a lot as well. It's really hard to take our officers off the streets and not have it funded, which is 100% understandable. So we want to make sure that there's funding for our CIT programs. We want to expand to more counties, and we want to have some minimum standards. So there's a real strict CIT training. Not everyone can manage that depending on their size of their program and so forth. So we want to make sure that there's a minimum that officers are trained in, so that when they're out in the community, they can they have a better understanding of the interactions with people and what it looks like when someone's having a mental health crisis or someone's having issues with addiction. So looking at the minimum standards, funding, and then ongoing competency standards, ongoing ways to keep the programs up. So the other thing we hear a lot is, well, we trained our officers in CIT, but then there was no well, do they understand it? Is there some more training we need to do? If a year goes by, are there new recommendations? What happens when those officers retire or leave to a different community? So improving our training, expanding it, and then making sure we continue to keep an eye on that. And we also, and this is something that Ray is very passionate about, and Ray brought this up, so thank you, Ray. We had considered using this in tandem with Stepping Up. So Stepping Up initiative is a national initiative to reduce the number of people with mental illness in the jails. It's kind of county specific. Currently, there's about 540 counties nationwide using this. Only 3 in Indiana at this time are involved in the Stepping Up initiative. And it provides county leaders with the resources that they need to reduce the number of individuals in their jails who are struggling with mental illness. It's very concrete, collaborative, and it's data driven. And that's one thing that has been a weakness of CIT is there's sometimes not data to look at to say, well, what are we trying to improve? What numbers do we want to reach? And so if we can combine Stepping Up and CIT, I think we're going to have a really good approach at this first Intercept and prevent people from even having to engage further down the criminal justice system.
And if you don't mind, I would just add that this Intercept specifically is really focused on that diversion to treatment in lieu of being arrested or booked into jail. So it is extremely critical that we give people the resources to do that are in those situations.
Yeah, absolutely. Thanks, Katrina. And this is where some of the other committees are looking at those subacute centers. Where can someone go? Where can police bring someone when they're in a mental health crisis? They need to keep people safe, but jail is not the best option. So absolutely looking at, as Katrina said, diversion so that people don't have to have that further involvement.
I would just like to also add that I understand when you speak about the data, but Fort Wayne and Allen County, they did, I know at one time we're kind of like the gold standard for working with CIT and hopefully diverting persons with mental health issues away from jail and into treatment. And I don't know if they're still up there, but I believe they probably are. All right. I see you smiling, Lieutenant. Take it off. Take it away.
I'd like to think that we still do a very good job. Statistically, less than 1% of our encounters that are dispatched as a mental health crisis, less than 1% of those end up incarcerated. We've had a kind of a rule of thumb, and it may sound simplistic, but it's a mental health crisis will trump a misdemeanor charge, but the felony trumps the mental health. If we have a serious felony charge, obviously we have to address that. But the old ideas of the public intoxication, trespass, disorderly conduct type charges, that because of no place to take a mentally ill individual, they would find themselves in jail and then maybe there for however long it might take for a 72-hour commitment type thing, when that's all we had, was the way to go. It was when I started law enforcement 34 years ago. Now it's, vast majority of those are going in for at least a more in-depth clinical assessment through behavioral health in lieu of going into the jails, and we've done that since we started our program here 20 years ago now.
And I would also like to add that Major Sam Cochran, who is one of the founders of CIT, also stated that CIT being complemented with the Stepping Up initiative, as Dr. Negendake stated, on a county by county basis, can even further reduce the possibilities of a person experiencing jail, which will only aggravate or exacerbate a mental health condition. All right, and hopefully we can get them into treatment. Treatment can be effective. Thank you.
Thank you. Great comments. I appreciate that. All right. So if no more comments on Intercept 1, then we can move on to the next slide. So you'll notice we don't have an Intercept 2. That's not because we're not thinking about it. So Intercept 2 is the initial hearings and initial detentions Intercept. And we have begun talking about some interventions at this level. It's really that post-arrest diversion screening. There's some great screening tools, one being the brief jail mental health screen that officers can use when anyone comes into a jail setting and so forth. So we are fleshing those out, and we'll be hopefully bringing a few forward later on. So I don't want anyone to think we've ignored Intercept 2. Intercept 3, this is really the jails and courts, and mental health courts we have them in Indiana. We want to expand them. They're really, if anyone has ever been to a mental health court, it feels completely different. It's very positive. It's very treatment oriented. And it's just very inspirational, quite honestly. So we want to be able to expand the mental health courts, increase the number of courts available, focus at that local level, and recognizing that not all communities are large enough to have their own mental health court. So how can we partner in some way so that all individuals have access to this type of intervention? Along the same Intercept, so Intercept 3, we think that competency restoration is something that we can make a fairly rapid change to. Currently, some counties we have made some changes in Indiana around our competency restoration. So I should take a step back and state that for those who don't know what I'm referring to here, when you are charged with a crime, you cannot move forward with that unless you are competent, which means that you understand the charge and then you can assist with your attorney. For some individuals who are experiencing acute mental health symptoms, they may be found what we call incompetent to stand trial, meaning that it's not ethical to continue with the case because the person doesn't understand what's happening or can't assist. And so we want to provide treatment. In many places right now, what's happening is individuals will need to wait in jail, oftentimes untreated because they don't understand the need for treatment, wait for a hospital bed in our state hospital system. There are some counties now who have started models using outpatient competency restoration or jail-based. So instead of having someone wait in the jail until they can get into the state hospital for treatment, can we go into the jail and assist them and run through treatment, but also through the education around the courts and what needs to happen for someone to be considered competent to stand trial. We think that this will make a big impact, not only in the jail population. It's very hard for jails to have someone in their system who with untreated illness. It takes a lot of resources for the jail, and it also is not healthy for the person. We know that longer someone goes untreated, the more difficult it is to treat those symptoms. And we also know that there's some damage that can occur to the brain the longer someone is going through some acute symptoms. So we really want to make an impact here. There are many competency restoration programs already in other states that utilize the outpatient and the jail-based. So we don't need to start from scratch. We know they work. There's a lot of data around that. So this is something we feel we can actually make an impact on fairly quickly. We do need to make sure that the justice system, everyone involved there, understands what we're doing and why, and have good collaboration there. Another issue that we have is the issue of involuntary medication within the courts. Many times when someone is found incompetent to stand trial, because they're having those acute symptoms, they don't have insight into the need for treatment. And if you don't have insight into the need for treatment, you're not going to feel like you need to take medication. So involuntary medication would be something that we can assist people with. We know we need to balance that, obviously, with civil liberties and civil rights, and then the health and safety of the individual moving through the court system. So that's something that currently we don't have in place, but would like to discuss that further to see how we can make those changes. I think I touched on everything in Intercept 3. Questions or comments on that one? That's a little hard to explain if you're not involved in the system. Did everyone understand that?
You explained it very well. I'll just add that this is sort of that small but really important piece, right? Like the volume of folks is not that high, but you talk to any sheriff that runs a jail and they'll tell you that these are the folks that cause just all kinds of backlog sort of system wide. And so it's small, but it's really important, and it's also tangible and actionable. So that was, I think, the main driver of doing this.
Yeah,
Probably the most in the weeds we're going to get in terms of our entire set of recommendations. It's an important.
Okay, great. All right. And let's move on to the next slide. So the next slide, we have Intercept 4. That's the reentry from jails, prisons, and hospitals. And this actually was just discussed in the prior subcommittee, talking about Medicaid expansion. Many people don't know that once you are incarcerated, your insurance does not go with you. So without insurance coverage, treatment is very expensive. It really falls, to the counties and to the states. And so when you're stable on medication, for example, and we know that many of the medications that stabilize people, especially the long-acting injectable medications and so forth, are really expensive. And what happens is someone goes into the jail system and they can't get that, right? And so they may not do as well. And so we really want to make sure that people can be treated with the best medications we have to offer. We know newer medications have less side effects and so forth and are better tolerated. We want to be able to provide that, but we need that Medicaid waiver so that people can obtain those. And I think with the Medicaid waiver, it would be easier for community mental health centers to come into the jails and to provide care. And really the community mental health centers are the best agencies to do this type of work because they have the most expertise around individuals with severe mental illness and addictions, and can help collaborate and coordinate care when someone's released. So it would allow, instead of having private entities come in and providing those services, it would allow the community mental health centers to come in and provide services. The other thing is not only would it allow for the behavioral health medications, but also the MAT is medication assisted treatment, which is treatment for individuals with substance dependence. This is really critical. Some of the jails and prisons will allow some of this to start prior to release. What we know though is that when someone is released from jail or prison, it is a high risk time for overdose, high risk time for relapse. Individuals will sometimes go back to their pre-incarceration level of use, even though they haven't used for a while. And that's a really high risk for overdose because their bodies are not adjusted to that. And we really want to make sure that people are in the best position possible to maintain their sobriety and continue to do well once they're released. And then that would also prevent recidivism and that revolving door.
I would also just add that it's a nice warm handoff for someone to continue that treatment upon release and have that peer support or that community link. We know connection is so critical, especially with substance use disorder. And that was the intent, I think, in the development of the Intercept model for reentry.
Yes, absolutely. And I think I'll touch on that also. I think we have one of our Intercept 5s that will touch on that a little more, but you're absolutely right, Katrina, thank you. Looking at the Intercept 5, so this is community corrections and community support services. Again, we really need some data. It's very important not just to know, are our interventions working, right? So we think they're going to work, but are they working? So we need that data to make sure that we are moving in the right direction. And also data is really important for future legislation. So for example, in Michigan, we were funded $500,000 at one of our county jails to create a jail diversion program. We had a 1-year time frame. And in that time, we saw great results, right? Decreased recidivism and so forth. We also saw that with that initial 500,000, we were able to save the county 1.5 million. And that really spoke to the state legislators, and they said, oh, well, let's continue to fund, right? So there's a lot of reasons to make sure that we are thinking about data collection as we move on with these recommendations or move forward with these recommendations. I think we have one more slide. Yes, okay, and so still at Intercept 5, and this is what Katrina was also referring to. If we have community mental health centers working with individuals in the jails and prisons, it is really a seamless re-entry into society as far as their treatment. So some of the jail diversion programs that I've been involved in, a patient could see me in the jail, they would see their peer support, their case manager, their therapist, and that exact staff would see that person as they were released and being seen in outpatient. And it was always more than a pleasure for me to be able to say, hey, this is my last meeting with you in the jail. On this date, this time, you have a meeting with me, at my office outside, right? And we would have our peer supports pick up the person when they were released and take them where they needed to go. And so this is really where that continuity of care comes from. And it's so much easier for individuals to continue with care if they already feel comfortable with their team, right? There's so many changes, obviously, when you're being released from jail and prison and trying to get back into society. Sometimes if someone isn't already working with you, the mental health treatment component sort of falls away as you're trying to do all these other things, trying to get housing and trying to make sure you have food and so forth. But if you already have that team working with you, then they're going to keep checking in with you and make sure you continue in your treatment. So that is part of that seamless transition of care. And in this, we really think we need more forensic peer supports, people that really understand the system and what it means to be involved in the system, and then what it means to be out in the community and to, again, just have that maintenance of care.
Dr. Nickendang?
Yes, sir.
I am a forensic peer support specialist, and I have had the honor to work with some of my fellow vets while they were at the Indianapolis pre-release re-entry educational facility, and also at Plainfield. And I helped bring them out of prison into housing, work with them, and so far, knock on wood, none of them have returned to prison. It can be great to meet someone like me. I've been out of prison over 35 years.
Yeah, that's wonderful, right? Thank you for sharing that. And I think that bringing that knowledge really helps you also, right, to connect with individuals.
Yes,
and the housing you mentioned, I know that was mentioned in the first, our first subgroup, but that's part of this, right? We consider housing as treatment. So that's critical, but you need someone to help navigate that, right? So I think that's absolutely a great point. Thanks, Ray.
Thank you.
I think that's our last slide. So any other questions or comments about our recommendations?
You did a great job presenting. Thank you.
Thank you. And thanks for all of your input.
All right, well, thank you. That was great, and there's a lot of information, that was organized, I think, in a very thoughtful and logical way. So we really appreciate everybody's work on that. All right, moving right ahead. Children, unfortunately, and Brooke can speak a lot more about this than I can, but our children are not doing okay as it relates to these particular issues, and we have a very important task as an entire system to address that. And so really, really happy and proud of this group to, Bray, do you have something to add?
No, I'm sorry.
Okay. Yeah, no worries. So we have Brooke Lawson and Chase Lyday. We're the co-chairs of this group. And I think, as you'll see again, they did a very, very good job of distilling a very complicated set of issues and things we can move forward on. So I don't know if Brooke or Chase, if one of you is doing this.
Yeah, I'm happy to kick us off, and then I'll let Chase jump in wherever he'd like. But like Jay said, we really, we spent our time talking about the various systems that support and serve Hoosier children. And we were actually able to kind of categorize our conversations in 3 different buckets that we'll talk about in just a minute. And we actually have them identified by priority. So if you want to go on to the next slide, we'll start with the first priority being making sure that all Hoosier children and families that are in need of behavioral health support services have access to those services. And so when we're talking about behavioral health services, we're not just talking about outpatient treatment. So we're talking about the spectrum, including peer supports, which I think is something that has been discussed, but not necessarily something that has been implemented with youth, as well as, we see a large gap between outpatient services and then inpatient services, and making sure that there is a time and a place for intensive outpatient programming for children. And there are children that need it. And so making sure that those services and supports are available for students that might need those. And then also, I was excited to hear that other groups were talking about parity, because we had some conversations as well. Just knowing that the different payers of insurances for children don't always cover the supports and services needed for children. So making sure that that children and their families get access to the services and supports they need was our number one kind of recommendation. Secondly, we really wanted to invest in proactive, preventative, and collaborative approaches to supporting at-risk children and families. We didn't want to be extremely prescriptive on this one, because we know every community is different and the resources and supports that communities have access to is different. But really talking about moving away from zero tolerance policies to more trauma-informed practices that include youth and family voice. So when we're thinking about students who are struggling and maybe making some bad decisions, that we're considering how do we approach that in a trauma-informed manner, helping students learn from the maybe mistakes that they make, talking a little bit more about restorative approaches also to discipline. And then including behavioral health supports as well when we have at-risk students in the community, and making sure that that's a community approach. And then providing some trainings for those organizations that serve youth. Again, we didn't want to be prescriptive about what that was, because every community is different and their needs are different, but making sure that they all had training necessary to really support these difficult situations in a preventative, proactive, trauma-informed manner. Chase, I don't know if you have anything to add to this one. All right. And then we'll go on to the last of our recommendations, which was really to prepare all Hoosier students for lifelong success. And we talked a lot about, having a framework for social emotional supports that's really linked to high academic achievement. So understanding how these supports really do support high academic achievement. They're not taking away from academics, but really supporting students in reaching their fullest potential. And talked a lot about implementation supports as well, making sure that everyone in the community is involved in the implementation of these supports and services, including schools, parents, teachers, community members, community serving organizations. We know it takes everyone in the community to raise healthy, successful children. And then lastly, just thinking about the different support positions. So we really believe that behavioral health supports are important in schools, but also schools need to have school-based professionals that are actually employed by the schools that can support children as well. And so looking at making sure that there's funding available and resources to really collect data around successful implementation of this work. So I'm sorry, I should have stopped at each bullet for comments, but I'm happy to answer any questions that anybody has about our recommendations.
I have no questions, Brooke. I just wanted to make sure to publicly thank you and your colleagues in the school mental health space for holding the line and kind of staying focused on our kids in the face of, I think, a lot of kind of bad faith misinformation that's out there. We really, really appreciate it, and we know it's not easy. And so, we're speaking just for myself and not the commission, but I think we are happy and honored to back you in any way that we can. So thank you.
Well, thanks, Jay. Our kids are too important to not do this work. So
Absolutely. All right. Well, thank you so much, Brooke, and the rest of the subgroup members. Again, there will be plenty of opportunities, I think, to weigh in if anything strikes you later. So I sort of lied earlier when said that the next two. So this next one, I think, along with criminal justice, is the super dense one. So I'm going to go and turn it over to Dr. Carrie Cadwell to examine. I think probably we can all agree is the number one driver of many of the problems that we're talking about right now, which is behavioral health workforce issues.
Thank you, Jay. This is Carrie. Can you hear me okay?
Yes.
Okay, I just wanted to make sure. I apologize. I like to say my car is my office, so I hopefully will be in a spot that I can get on video here shortly. So on the screen in front of you, you will see the charge of the subgroup, and then in addition to that, all the subgroup members who participated in our committee meetings. Everybody had really phenomenal ideas, and so I really appreciate them being very active members in this process. Part of the way that well, first let me say, I think one of the really great things about what we're doing today is I think across our committees, we can obviously see where there is a lot of alignment. And a lot of this, and you'll see some similarities in the recommendations for the behavioral health workforce group. And I'll explain a little bit more about why this is specific to workforce. How it is that we went about this is both considering that the charge of the BHC is to think about the system as a whole, right? And then also thinking about that there is a need to address for children, youth, as we just talked about, and in addition to that, adults, serious emotional and mental illness presentations and substance use disorders, which may be a little bit more of, in some cases, a specialty niche for certain systems. Most of you would have received the survey that we developed. So our process was we did a survey that looked at workforce from a number of different vantage points. One might be recruitment, retention, early development of, building capacity, issues of short-term capacity building, and then long-term capacity building, how we qualify people in behavioral health, and then also how we optimize individuals and the behavioral workforce that we have today. And I would agree, and I think everybody on the subcommittee would agree that many of the things that we've talked about already today on this meeting are predicated on the idea that we have the workforce to be implanted within multiple layers of a system And today what we find is that we have obviously a limited pool that we're just moving around amongst ourselves. So if we want to go to the next slide, then we can start to talk about the recommendations. So out of the survey, which we can forward to the entire commission, I can't remember if we did that or not, we had ideas around all the different areas I mentioned, but then we also had a survey question, which, you know, I'll basically say is kind of like, what do we consider to be the house on fire issue? Like if we're going to tackle something, what do we consider to be those things that we really need to invest in now? And then we'll take a look separately at all the other, you know, recommendations that came under a lot of different areas. So one of the things I think, you know, we've talked about in this committee, but then also at the same time, I think clearly connects to many of the things we're talking about today, is really looking and recommending a Medicaid rate study. Now, we're not recommending that we just look at all rates, right? We've really targeted several that we feel are really important to building expansion. I think we can say that, you know, this is one of the hardest things to tackle, is the idea of rates, right? It's not something you can move instantaneously, or, you know, it takes a really long time. But we have to start this process really now. And for all of us, whether we heard from when Maria testified in front of the commission multiple months back, to any one of our experiences with as being a behavioral health provider and or system, you know, when you have a fixed cost reimbursement that really has not changed, but most of your other costs within your business have a variable component to it, unfortunately, right, you can only ever do so much with that fixed rate reimbursement. And so we really do need to take, and the committee is recommending, a Medicaid rate study of select behavioral health and substance use specific service types. They include the specific psychotherapy codes that are used by behavioral health providers, Medicaid rehab option rates and structure, certified peer recovery service reimbursement, and substance use disorder treatment residential, and also the transitional residential per diem. So those are several components that we're recommending that we take a really close look at. It's not to say that every rate couldn't use some look, but if we're really going to say what's something that if we were to really target, make some difference in, could potentially turn the dial on our ability to bring new, recruit new talent to our behavioral health system. And in addition to that, you know, be able to keep people in our system because we're able to pay them sufficiently, then these were the ones that we really were focusing in on. So I will pause there. I don't know if anybody else from our subcommittee wants to mention anything on this front, or if anybody has any particular questions on this recommendation. Okay, I'm going to assume not, and I'm going to go on to number 2. So in the case of number 2, what we're really, and you saw this even from the continuum of care perspective that the committee that was discussed earlier, is we're recommending that we support legislation that requires the state to develop a plan for the continuation and expansion of the CCBHC grantee program, while developing infrastructure and implementation of a prospective payment system rate methodology, along with transition of all current CMHCs to the CCBHC, this is the Certified Community Behavioral Health Center model mentioned earlier, over a period of 3 years. CCBHC service requirements shall be considered an emerging best practice for comprehensive behavioral health services accredited by DMHA. And then also in that transition to a CCBHC model implementation shall consider needed support to Medicaid rehab option services during the transition, and then where essentially that particular program fits within the CCBHC model. Okay, so why is this a workforce issue? Because what other states are finding who have implemented CCBHC is that those CCBHCs, formerly community mental health centers, are in a much more robust position for recruitment and retention of employees. So that is extremely important to some of our most vulnerable, right? Those individuals that CMHCs are charged with in terms of serving individuals who have more chronic and persistent presentations of their mental health, ongoing substance use supports needed. And I think you hear throughout the committees this theme of, you know, where CMHCs are very critical, right? So while the rate study above is geared towards the system as a whole, this particular recommendation is geared predominantly to community mental health centers and the continuum that gets advanced, the ability to be responsive to all of the places who you heard, whether it's jails or other that we need to be responsive to, and to ensure that we're able to bring on the workforce that's necessary and to keep them within our systems during, actually for a very, very long time. So on that note, I'm also going to pause, and if anybody from the committee has additional statements they want to make, or if somebody has a question about this too. Okay, all right, well then we can advance to the next slide. Okay, so in terms of this idea of qualifying, you really can't dissect the idea of behavioral health workforce development from how it is that we qualify people, which includes licensing, and then also includes 3 and 4 kind of tied together, is how our Indiana Professional Licensing Agency functions. So under licensing and compacts, we are recommending that we support legislation that expands military spousal licensure recognition language to behavioral health license issued under the State Psychology Board and also the Behavioral Health and Human Services Board, while simultaneously supporting the implementation of physician and psychology compacts, as well as other future compacts advocated for by IPLA recognized behavioral health professionals. So that is, I would say, very dense. So let me jump back and explain this a little bit. So what we're really looking to do is to enhance this idea of reciprocity. And when people think about reciprocity, I think they just think about it in terms of the basics of, hey, we're having somebody come in from another state, and therefore we're setting up criterion under which, we're maybe vetting them differently. And reciprocity in its true nature has a couple different components or methodologies or ways you can look at it, right? When people want to come to Indiana, and then number 2, when we have Indiana practitioners who, although we have plenty of need here to meet, may want to consider practice, right, in another location. So there's basic reciprocity, right, which is some of what we have today in Indiana, where laws are developed around certain licenses that says this is how we'll vet already existing licensed people from other states who come into our state and want to be licensed here to practice. A second component of this might be agreements that exist literally just between states that say, okay, and I'm making this up, I don't think exists today. Illinois and Indiana, they decide that they want to have an agreement between themselves on, certain licenses and the ability to move between the 2 states. Then you can also have compacts, and compacts are multi-state, really, agreements that have a multitude of different layers to them and quality controls that allow for saying that, hey, people who become a part of a compact agreement, so in the case of, let's say, the psychologist compact agreement, that, if you are a psychologist and you opt in and go through all what's necessary to be a part of the compact and you're licensed in a state that's compact eligible, then you're really going to be able to practice amongst a number of states who have agreed to this particular compact. Something to note about compacts is that not every discipline currently has a compact. So there are some behavioral health disciplines that are either in the process of establishing a compact and or are trying to get states to agree, enough states to agree to be able to do that. So today we have the ability to do a psychology compact, so psychologists, and then also there are physician compacts out there. There's also an additional form of licensure reciprocity, which is really, in its simplest form, uniform licensure recognition. And there are some states that have gone towards this. And this is the idea that, if you have been practicing in another state, and so I'll use, because I'm a psychologist, so I'll use that as an example, but it could apply to LCSWs, LMHCs, LMFTs, you name it. So if I'm a psychologist and, I have been practicing in the state of Indiana for 5, 6, 7 years, right? And I want to go to Ohio and practice. So the idea here is if Ohio had universal licensure recognition, part of what they would look at is, and I should mention, let's use Arizona as the example, because Arizona actually does have this. They'll look at the extent to which, okay, I meet their basic idea of I'm licensed, I have been practicing for a minimum number of years, I meet the basic background check, and in addition to that, my scope of practice is basically the same. And so if I show that I'm a capable licensed individual, that, that it creates an easy path to licensure within this other state. So the idea is here that Indiana really needs to move forward in becoming a state that makes licensure for behavioral health we want quality, we want safety, but we want ease, right? The same way that we say we need access for patients, we need ease to create licensure paths among a number of different paths, not just one, for behavioral health providers and physicians, psychiatrists, APRNs, in order for them to establish practice in the state of Indiana. So that's really what that licensing and compact piece is about. So I'll pause. Does anybody have any comments or questions?
Dr. Cadwell?
Yeah, Sharon, go ahead.
Hey, I just wanted to jump in and say there are 27 jurisdictions that have enacted the Psychology Compact. 22 are currently in effect. And that means if you are licensed and participating in the compact in one of those jurisdictions, you can either practice via telehealth in the other jurisdictions, or you can choose to temporarily practice physically in those states for a certain number of days each year in each of those states. Yeah, I think that's really all I needed to say about that. I just wanted to put that piece in because we're now looking at more than half the country participating in the PsyPact.
Thank you so much. And I think that highlights, right, how important it is for our state to look at all the different pathways to creating ease to licensure while still assuring safety and quality amongst our practitioners. So this also then connects to the next recommendation, which is really the modernization, supporting the modernization and increasing digitization of the Indiana Professional Licensing Agency licensing process. This approach was taken with the Indiana Bureau of Motor Vehicles with solid success. So the idea here is that, and we have seen for IPLA, the increasing use of digital forms, right, and other things, but there is still many different options that could be considered to continue to modernize the approach. And so I think when you talk to a number of people, and, and Sharon, you may even have some comment that you want to make here, is, there is still a lot that has to be I'd say manually monitored, tracked, and in the agencies that have people who are applying, what we see is, a lot of, because again, it's a lot to manage in a non-digital world is, something got lost, or something might not be tracked well, or something has to be resubmitted. And so we really want to support, number one, those staff that are a part of IPLA and all the boards, and being able to have as much technology, right, to that process as is possible, so that we can, again, not only support them in that process, but create a more efficient path to licensure for folks. So I will pause there if anybody from the committee wants to make a comment or anybody has a question.
Dr. Cadwell, I would jump in and support what you said. The timeline for trying to get licensed in this state is extremely difficult because it takes so long for your paperwork to pass through, for the staff to have the opportunity to review it, to let candidates know if something's missing. And from a candidate standpoint, I can say it is extremely frustrating. I've been, for example, working with a candidate here in the last week who has been trying to get his HSPP approved. And he's been working on that since July. It turned out his paperwork was all there, but the staff didn't realize they had it all because of everything else you've just discussed. So it's difficult. And I think it probably hampers our work.
This is Donna Cully, and I just want to comment and make sure that the commission does understand that the issues that this group has addressed is directly and intimately related to access for the people in our community. I mean, I think it's difficult to have a conversation about access without addressing the issues that have just been presented.
Thank you, Donna. I think that we on the committee, and I imagine so many other people on this commission would agree that what we're talking about here regarding workforce is absolutely foundational, right, to our ability to do anything to address the things that we have already discussed. So on that note, we'll go to number 5. So we are also recommending the development of a request for funding for use of COVID stimulus funds. And let me add this. So remember, part of what we were also recommending is we're thinking about like what are the house on fire issues. So we wanted to make recommendations that we could also potentially tag to what we know is going to be some planning that goes into the use of COVID stimulus funds for the state. So develop an RFP guideline for the use of COVID stimulus funds to assist in moving behavioral health service providers and recovery community organizations and community mental health centers to a $15 minimum wage. We feel like this is critical, right? I mean, if you simply look at some of the study and research that's been done, you know, you will see things like, you know, even an increase of $1 in a minimum wage can mean a significant decrease even in suicide risk because of the mitigation of financial stressors, better overall wellness, quality of life, and what a lot of times I think that people don't realize, you know, in maybe just in general, is that a lot of the people who are doing a lot of the work in the state for behavioral health, because we have a shortage, right, of licensed providers, is they are peers, they are case managers, they are technicians, right? Technicians in these inpatient units, in these residential locations. All of these pieces that we're saying are so critical to the continuum. You know, if you're making $11 an hour, that isn't probably going to be livable. And you're going to have to think about kind of trading up probably at some point. And so I think that we really wanted to advocate for the idea that we could probably create some initial supports through COVID stimulus funds while still ironing out, right, all of what we recommended in item number 1, which was that Medicaid rate study. And in doing so, really looking at the ability to help continue to support for a lot of those, I don't know, professional or in this case, paraprofessional positions that we're supporting a livable wage. Because if we're not, then it's going to be really hard for those individuals to do and continue to do the critical work that they're doing every single day. So any comments and or questions on number 5?
I would just add, if I could, I love this recommendation. I love all these recommendations, but you know, just as a case in point for our peers, you know, you're absolutely right. People have to be able to survive, and it's very sad when our peers leave because they have to, right? They have to be able to survive when they have such a passion and are so wonderful at what they do to help us treat individuals. In our community mental health centers, for example. But when you're going up against Costco and Amazon, right, which are paying $18, $20, $22 an hour, people have to make a decision. And I've talked to many peers who don't want to leave. They love what they do, but they also have to support their families. So I just thank you for bringing this recommendation forth.
All right, great. Well, if we can go to the next slide.
Before you go to the next slide, Doc,
go right ahead.
I just want to say that I wholeheartedly agree with Dr. Nigendale. All right, for the simple reason of the $15, that's okay. But you know what? No, ma'am. I mean, even that, if I remember correctly here recently, some data was taken that stated that even at $15 an hour, nobody can really support a family on that. So you know what? And what we do, I am a peer support specialist, proud one too. All right, and very involved. I actually own my own business, was just recognized yesterday, along with another agency headquartered in New York City. So maybe we should think about, let's kick that number up some.
Completely understand, Ray. I mean, I think that it's the recognition of the importance of the work, the professionalism, right, of that work, and, you know, the outcomes that come from it. So completely appreciate that comment.
Thank you.
All right, we can go to the next slide. I don't know if is somebody able to move it to the next slide?
There's a bit of a lag there, Gus.
Okay, great. All right, number 6, tuition assistance, scholarships, and loan repayment. Again, talking about COVID stimulus funds. Recommendation is to use COVID stimulus funds to fund tuition assistance and scholarships and loan repayment program options for behavioral health and recovery professionals, including certified providers, so not just licensed providers. Consider long-term funding, excuse me, through licensing fees that may increase should we expand licensure recognition. And that again goes back and is connected to recommendation number 3. There should be an associated commitment to serve and prioritize funding based upon regional needs and equity issues. So this is the idea that we could really make a dent in supporting people getting into the business and or enhancing where they are, right, with further certification or potential licensure. So that was one of the areas that the committee felt strongly about. Again, I don't know if anybody on the committee wants to make a comment on this or if anybody has any questions on this front. Nope. Okay. All right. Number 7, we've all talked a number of times and I've heard telehealth come up several times. And so we are also recommending that we enhance the recent telehealth legislation to be inclusive of all providers recognized by the state for the purposes of certification or reimbursement. So really what this gets at is, from a workforce perspective, is that if you want to create access, what we do know is that when you enhance the tele ability, that access tends to go up, right? We're not saying tele really replaces when we have a need for in-person, but what we can say is that the consumer demand may be different than the physical health space completely. Behavioral health has been transformed, okay, by this COVID experience and really optimizing telehealth. So when we're talking about the optimization of workforce, when we're even talking about the recruitment of workforce, or we're talking about creating access, telehealth is a critical game changer that really needs to be continuously supported and furthered in the case of behavioral health support. From the recruitment standpoint, from the consumer standpoint, let me say this, what we see is that access not only has to be there, but there has to be convenience, right? So, not everybody will be able to take off work for 4 hours. Behavioral health is a commitment to potentially weekly, several times a week, and or every other week services. And so when you're asking people to do those things and to have family lives and to do and be there for their children and to make sure that they get to the appointments and to make sure that they don't miss too much work, you really have to create convenience for them, whether we're talking licensed and or in this case, non-licensed, certified, or reimbursed individuals under various payers, and in particular Medicaid. The second component from a recruitment piece is that, and maybe others have commentary on this, is that, the game changer under what's happened with COVID really is this, that when you go to hire somebody today, you're not talking to somebody who says, hey, by the way, all the time. Some people are absolutely pro doing all in person, but increasingly what you see applicants asking about is the ability to leverage tele. And is there some flexibility in how I'm going to be able to work, where I'm going to be able to work? So even our workforce that we're recruiting is in reality starting to expect something different in what work life looks like in behavioral health. So the expansion of tele is absolutely related to workforce and developing that. So any questions on that front? No? Okay. So I think we have a repetition, so we might be missing one. Well, why don't we go to the next slide? Number 8, we've already talked about. Okay, so I know what's missing. So what's missing here is that we are also recommending that a comprehensive campaign be undertaken to start to educate youth as early as middle school on behavioral health professions. So similar to what we do with STEM, whether we create public-private partnerships to support behavioral health workforce awareness, but the development of workforce and the ideas that people can think about what are their options in behavioral health. We need to start young. We need to start with youth, and they need to be educated on this front, not just from an awareness perspective, but from a career option perspective also. So that's one of the ones that is missing in this. But number 9 is the study of criminal record as a barrier to employment. So this is the recommendation to undertake study regarding the barrier of criminal record barriers to employment and behavioral health, including certified peer recovery positions and other behavioral health professionals. Now, this is one that Katie, you had brought up. So I wonder if you have something that you want to mention on the front of this as a barrier to employment.
Yeah, absolutely. Thank you, Carrie. So this issue is intimately connected to our contracts with Department of Child Services and the ability to hire providers with life experience. So as you know, those in recovery often have criminal records that are not yet expungible. It takes 8 years to get to that point, and there's a lot of very wonderful people that we would love to hire, but we're not able to, as they're not able to pass those background checks. So there is in Indiana code, there is a list of those non-waivable offenses that DCS will not waive because of what's written in the code. And so the recommendation would be to look at that to see if there's any movement we can make to support those to get into the workforce. As peers, as case managers, or whatever profession that they're eligible for, and find a way around these criminal charges and those employment barriers. It is a huge burden to at least us as a community mental health center. Often we find wonderful people to hire and then find out that we're not able to because of a charge that happened 5 years ago.
I would agree with you, Katie. Is there anybody else who wanted to make a comment or have a question on this recommendation? No?
I
Okay.
just,
Oh, go ahead.
yeah, sorry. I just wanted to share that the DCS, we, in the past year and a half, formed a Racial Justice, Equity, and Inclusion Advisory Council, and we have discussed that very issue that you just addressed. We've asked providers to change their requirements to be able to include more lived experience folks who are working with the population in our communities. And so it is absolutely something that DCS should look at to be able to include that, as well as not only is it just best practice, but it's also, I mean, we are struggling as well to find family case managers and folks that could be working with our people right now. And that would be an excellent opportunity to get more people with lived experiences involved in just case planning. So I just wanted to share that we have been talking about those things for our providers. And I was just talking to a DM in Delaware County yesterday about this very issue.
Great, thank you very much. Well, Jay, I think we got through all of the denseness that you referred to, lots of recommendations. And so I'll hand this back to you, and I appreciate everybody hanging in there while we went through it all.
Yeah, absolutely. Thank you so much. That, it was dense, but I think, it probably could have been longer and denser. So I think you did a very good job of explaining the context and everything. Okay, so we have one more, and that's me again. I was the de facto chair of the Suicide Prevention and Crisis Subgroup. And we'll be honest, we sort of, the one thing we did was we sort of hijacked this group a little bit to push the only thing that matters right now in suicide prevention and crisis response. And so we'll get to that. There's only 2 recommendations, but they're powerful and impactful. So you can see the subgroup members there, myself, Dr. Negadank, Dr. Nassett, Sheriff Nelson, Mayor Fadness. And I would, if you haven't yet, I would take a look at our minutes if you haven't, if you're interested in kind of understanding how this flowed. But I can go into the next slide. We just want this commission essentially to go all in on 988, which is what we're doing here at the state. So 988 is the new 3-digit number for suicide response and crisis responses. And we at the state are adopting the Crisis Now model, or some version of it at least. I think we're gonna modify it to suit our own needs, but it's a 3-part approach: someone to call, someone to respond, and somewhere to go. You can see what all that entails there, and obviously we will flesh it out considerably, but when and if it becomes a recommendation. And then so that number 1 was just to, again, reinforce the Crisis Now approach, which I think we're well on our way to doing already. And then number 2 is, I think, one of the most important things that may or may not come out of this subgroup of this commission, and that is the possibility of a 988 surcharge for crisis response and suicide prevention funding. And so the way this works is similar to the 911 surcharge. This allows states to impose a small surcharge on cell phone bills to perpetually fund both crisis response and suicide prevention services. I believe 3 states have done this already. In Indiana, we haven't done this, but we have created a pathway to do it by creating the fund that it's going. So we're, I think, well ahead of the curve there. And so we would love the commission to support in its ultimate report this surcharge. So any questions or comments here?
Jay, did you guys talk about the amount of the surcharge or the total amount needed, or is that for further study?
We haven't. I mean, I think we've talked about it internally. It's one of those things, Steve, I'm sure you know, we don't want to put the cart before the horse here. But certainly welcome any commentary or feedback on that. I mean, I think we're not talking about a lot of individual money here. I think a lot will go a long way, or a little bit will go a long way. So, but it's certainly open up. I'm open to the group's feedback on ultimately whether or not we should actually put a number on there. I could see it going both ways. So, as I think we saw with the cigarette tax.
And I don't know. Maybe this is a discussion for your next agenda item in terms of the next phase of the work. But I would just throw out there, for whatever it's worth, that we need to be able to fund the system, not the call center.
Yeah. Oh, yeah. This is all of it. I think the allowances in 1468 are pretty broad of what that could be. And actually, we should probably pause here and just take a moment to recognize Representative Steve Davison, who unfortunately passed away. And I know Steve McCaffrey, you were good friends with him, and he was a real champion of this system early on. And so his family's in our thoughts, and just wanted to make sure we did.
Thanks.
Jay, I have a question about the mobile crisis teams. I'm just interested to know when, who's on the mobile crisis team, just given, we know there are workforce issues. And so thinking about mobile crisis teams for every community, what is your recommendation as to what that looks like?
Yeah, thanks for that question. I mean, obviously, I think that just to echo what Donna said about workforce being a driver of everything, right? And this is no exception. And so I think our buzzword is flexibility here. I think that you'll probably see this upcoming session a legislative approach to add even more flexibility to the concept of mobile crisis. I think we sort of need a bare minimum of I think quality control, but recognizing that peers, for example, are probably one of the most important pieces of the mobile crisis team, and that it's not just like exporting an inpatient unit to the field. Like, it's a very different kind of concept. And so we're actively looking at that, and workforce is one of the things that we are very cognizant. I think one thing we always strive for here is kind of finding that line between best practice and possible practice. And I think that nobody has done any favors by insisting on best practices if they're not realistic. Right? So, it's a good question. Thank you. All right, any other questions on the suicide prevention and/or crisis? All right. Wow, we are an hour ahead of schedule, which is fantastic. I think probably the shift to virtual had something to do with that, but I think that I'd like to think that the quality of our recommendations maybe played a small part in our expedience there. So next steps, I guess. What are we looking at? So I think that we, number one, I think each subgroup is going to have to meet probably at least one more time. So our staff will be in touch to do that. I think we can continue to do that virtually, just given the fact that everybody is across the state, and we expect the PHE to continue at least for the next few months. So I think we should be able to do that. And I think that we'll have to kind of take a look at each recommendation, and we'll have to probably have to do a little bit of paring down. I think that while I love that there were 10 workforce recommendations, I think that having 10 final ones in the report may or may not end up diluting the impact of any particular ones. And then I think also, but on the flip side of that, though, I think what we'd like the entire commission to think about, and we don't need to jump into it now unless somebody has something really burning to say, is what's missing. What did we miss? I'm sure we missed something. I mean, we divided up into these 6 groups, I think, with clear eyes that we're probably going to miss something by this division of labor. So I think that it's a very important question to throw out to the subgroup. What is missing? What needs further exploration? We still have time to tackle a couple of things. Again, I would like to just be mindful of the notion of concreteness and feasibility when you're talking about what's missing. I think that obviously we all have kind of pie in the sky ideas about what the system should look like, but we need to think about what's actually actionable. So I'd invite all of you to think of to digest what you've heard and learned, and we're going to send these out to everybody so they can look at it and let us know what you think is missing. And also other thoughts and feedback that comes to you. So I think what we'll do is we're going to send this PowerPoint out to the commission, as well as the folks that are watching. There's a commission email address that we'll make sure to flash on the screen again. And this PowerPoint will be posted on the website as well. So I think we'll probably give it a couple weeks for commission member and public feedback. And then probably start up those subgroup meetings again, I think probably just one each is enough, and work with everybody to get to the point of refining them into sort of a quasi final form. Although again, it won't be the final form, but it'll be to the point, I think, where we can probably have a vote and go and put some of our weight behind some of these things. So any questions on that?
Jay, I have a question. So I appreciate the opportunity to try to think of things we've forgotten. I'm sure there are things that we have, and I've been involved in a lot of the committees, but are you expecting, or your thoughts from a process standpoint when the committees meet again, are we just refining the statement, or are you wanting specific action steps that go underneath each statement?
Well, I think that the answer is kind of both, because I think there's a pretty wide divergence in the level of detail that the different groups put there. I think it's just an opportunity to take now that this has been presented to everybody, and hopefully we'll get some more feedback, via email or other things. So I think take that feedback, take anything else that we've learned. It's very possible that a subgroup or two could be like, look, we think we're good, we think we're refined, and we're ready to go, and that'll be a very short subgroup meeting, right? But it could be possible that another group is like, well, we didn't think of X, Y, and Z, or this particular feedback is really important, or we missed something and we should add into that, and that might be a little bit longer thing. So I think the answer is going to be kind of sort of group dependent. That makes sense.
Okay.
Any other process questions? Good question. Thanks, Steve. All right, just plugging right along here. So as you may know, we have a couple other obligations that the statute imposed upon us to put in the final report. One of them is an analysis of the cost of untreated mental illness. I just wanted to share that we are, sort of down the road of getting that analysis going, and we should have that in plenty of time to include in the final report. And there are a couple other things that we are obligated to take a look at, and we should have most of those covered through other studies that we're doing here at DMHA. But we're gonna take a look at what we're studying and compare it to the statute, and be prepared to report in more detail at the next meeting about the status of those, just to make sure that we fulfill all of our obligations that the statute places upon us. So if anybody wants to be involved with that, happy to just reach out. We're happy to include you in those conversations. But I think, these are, in this particular, this one is about, kind of academia and number crunching, that sort of thing, data analysis. So we didn't think it was an appropriate or useful thing to do in a Zoom meeting or in-person meeting with the whole commission. So we'll have that for your review whenever it's done. All right, well, we are done. So we're looking at probably December for the next all commission meeting. We want to make sure we can get Senator Kreider on board. And of course, we know we have to do it in the first half of December because everything shuts down more or less after December 15th, as it should. So first half of December, we'll get those scheduling emails sent out sooner rather than later, so we get it on people's calendar. Still TBD on in-person versus virtual. Would love to see all you guys, but I know it's difficult for some of you to make your way down here sometimes. So we'll have to see on that. Other than that, I would say any closing comments by any of the commission members before we adjourn?
Yes, Jay, this is Ray Lay.
Go ahead, Ray.
I hope I don't make too many people mad with this, but I'm sure finna say it.
Go for it.
The last part of December, I'm gonna be hanging out in the Caribbean.
Well, that's amazing, and you should. And you said the last part of December, right?
Yes, sir.
Okay. Well, we will do our best not to interfere with your vacation plans. All right.
Thank you.
All right. Yeah.
Are we
And
able to
I am a
hold
little
our-
mad at you just for teasing.
Sorry.
That's all right.
Are we able to hold our whole commission meeting in the Caribbean?
There. Well.
Hey, yeah.
There you go. All right. I'll start working on sponsorships for that. And that's an idea right there.
Punta Cana at an all inclusive.
That sounds amazing, Ray. There, it's self-care, right? It's like
That's it. I do a lot. I'm supposed to play a lot.
All right. Any other closing comments, commission members?
Jay, I just want to say how impressed I am with the amount of work this commission has done. And I think if these recommendations are able to be followed, we should definitely see a positive change in the state of Indiana.
Yeah, absolutely. Well, thank you for saying that, and thank you for your contributions. It's been fantastic, and I fully agree. We've done a lot of work in trying circumstances, and I think it's not close to done yet, but I think we should be proud of what we've accomplished. So, thank you all for that. All right. Well, look for some follow-up emails, like I mentioned, and look for these materials to come out. Please take a look, and please, don't be afraid of stepping on toes. I think open and candid feedback is our request to you all, and look forward to meeting in subgroups and then getting together very soon. And with that, we are adjourned. Thank you all very much.
Bye, everybody.
Thank you.